Hey guys, Tony here. Just wanted to introduce y'all to the first episode of Gross Anatomy, the tutorial video edition. I've been wanting to make a series that goes over just the major points of each chapter to kind of get a quick look at everything, look at the high yield stuff and how the clinical aspects relate, try to look at some different mnemonics to help us memorize things a little easier. So, without further ado, welcome to episode one. We're just going to be going over basic spinal injuries and processes, and how that can affect the back. So, to begin with, I want to start with the cervical spine. I have already written that here. And what I wanted to talk about mostly with the cervical spine is your vertebral artery. Now, the vertebral artery runs through the transverse foramina, right? And essentially, what's happening is that you have this artery running from C6 all the way to C1, and it's going through these foramina on each spine, correct? Now, running with that, you're also going to have, the nerve running next to it. It's not going to be running within the transverse foramina. Instead, it's going to be coming out of actually the intervertebral foramina, just like this. So looking at it from more of an anterior view, let's draw this out real quick for you guys. You get kind of these processes that end up looking like this. And if you realize I'm drawing what looks like hooks on the lateral ends of each vertebral body. Now these are important right here because essentially these are called your uncovertebral joints. Now the uncovertebral joints, these create kind of an extra facet right here, and this allows for extra pivoting and motion of the spine. Now clinically, this matters because they can actually compress the spine by undergoing a process called spondylophytes, I think. And let's give a lateral view of what these look like. So I'll try my best to draw this uncovertebral joint coming up, and I'll try to do it a little better. And as you can see, you have the pedicles of each cervical spine coming out. Of course, you have your superior facets, your inferior facets, and your spinous process. Now, you guys probably see where I'm going with this. You can see that there is this foramina right here that starts to appear in between these pedicles. Now, these foramina is kind of where spinal nerve comes out. Now, this spinal nerve essentially needs to come out comfortably, so when you get this condition that is called spondylophytes, we're just going to go with that, spondylophytes. It's actual excess bone matter that starts to accrue through these processes right here, through these uncovertebral joints. And what that'll do is it'll put pressure on your spinal nerve. And so these joints right here, again, this was spondylophytes. So the spondylophytes, again, just bony masses that come out, they start to impinge on this spinal nerve. And this can actually cause something that I'm pretty sure most of you are familiar with. It's radiculopathy. Now, radiculopathy is essentially defined by impingement on spinal nerves. And you can either have it at one nerve, so you can localize it, for example, at C5, which would affect all the relating nerves that come to it, or it could be multiple. So, well, it's a horrible M. Either way. So, or it could be multiple. So, for example, if you had C5, C6, and C7, this could relate to your musculocutaneous being pinched off. So that's kind of the first topic I wanted to get into. Next big thing we wanted to look at, was essentially the axis and atlas. So these kind of play a major role when it comes to uh, the articulation of the head. And let's just get some basic anatomy on it. We know that the atlas, for one, has no body, correct? It only has really lateral masses. So this guy over here, there's no body for him. He kind of just looks like so, with an articulation there. And he has these lateral masses and a posterior arch. So there's your posterior arch, anterior arch, and your lateral masses. So with that being said, your axis has kind of a similar shape, but it has this interesting, defining protuberance for it, and this is your dens. So if you looked at it from the lateral, it would essentially have this large tooth-like coming through here. So that would be called the dens. Now, essentially, these two cervicals, C1 and C2, they sit on top of each other. And if we were to draw them, again, laterally, you could see C1 would be up there. And then C2 would come behind it with its processes and have the dens actually going through, sitting on this articulation, this facet. And if we were to look at it again from a superior view, there would be the facet in blue, right? And the dens would be in green coming up right on top of it. Now, the C1 has two ligaments that essentially attach. It's a transverse atlas. This is transverse ligament of the atlas, and this thing will wrap essentially around the dens, holding it in place. So you can see with any rupturing of this ligament, you can have a dislocation here, but it's fairly well secured. And then even the dens will be connecting as well to your occipital. So it would be coming up in a fashion. And let's say this is your occipital. There's your greater occipital protuberance. And it will connect to these using your what's called alar ligaments. So I just wanted to show you just the relationship between C1, the dens, the alar ligaments. There is also one more ligament called I believe the cruciate ligament, and this essentially creates kind of a cross between the dens and the atlas. So the way it would look is if the dens was in blue, and then let's draw the atlas around it. You're essentially going to be having this ligament in black. So there's your transverse ligament. You'd have another one coming up top. This is the, I believe it's cruciform. Either way, again, it creates this cross which holds down the dens and really does secure it. Now, one big thing we should talk about is actually in the alar ligament. So this alar ligament, if ruptured, this will cause an increase in the range of motion for your contralateral rotation of your head. Contralateral. So essentially what's happening is that you have this dens, and if we were to draw again the occipital lobe above here, it has these ligaments attaching from the dens to the base of the occipital bone. And these ligaments, once ruptured, will not allow for stability anymore. And they essentially, this is what kind of keeps the head in check. You're not allowed to spin, you're not allowed to rotate too much to the left. You can't well, contralateral rotation. So you'd be looking at an angle. But either way, it stabilizes it. Once it's broken, you're at risk for damaging this area right here. So one last thing, just to kind of note that the occipital bone and the C1 make the OA joint, and the C1 and C2 will make the AA joint. So that is occipital atlas joint and atlo-axial joint, or atlanto-axial joint. So that basically covers what I wanted to go over for this area. Well, at least mostly the just the normal anatomy. One last thing we should go over. Let's actually start a new slide for this one. This is for the hangman's fracture. Now, the hangman's fracture, essentially, you can think of it as a guy, rope. Here's a noose. Here's his head. You hang a guy. This is where they got it from. And what this does is that it causes violent hyperextension. This violent hyperextension causes essentially an abrupt stop, and it completely destroys your C1, C2, and even possibly C3. I mean, it's kind of going all over the place. And you're breaking everything you can think of for your C1. So let's imagine that this is your C1 looking at it from a superior angle. There's your articular facets. There's the lateral processes, posterior, anterior processes. You're going to have breaks everywhere. You're going to have breaks here. You're going to have breaks here. And essentially, this can be mimicked if you're in a car accident. Your head flies forward. It can also, be accompanied with, so you have hyperextension, you stop real quick, then your head flings forward, and you have hyperflexion. Now, the hangman's fracture itself, usually you're going to, I believe, be preserving the spinal cord. So for this, you can preserve the actual spinal cord, but what's going to happen is that if you put continual pressure, you're going to damage it. So if you're, usually where this came from again, you're hanging, it's that constant pressure that's left on the rope there that actually causes the damage. If it's more of an instant, I'm sure it can cause damage, but for our purposes, I don't believe so. Okay. So for the next topic, getting off the hangman's fractures, let's go over the ligamentums, or the essentially the ligaments of the spine. So the first one we can go over. Let's start from the most anterior and work our way back. So let's cut a vertebra in half. So there's your spongy bone. And again, just a broken vertebra. So right in the front, big, fat ligament, very wide, broad. This is your anterior longitudinal ligament. And that's way too long for anyone to pronounce, so everyone just calls it ALL. Now the ALL, since it's sitting in front, it's going to be essentially preventing what kind of motion? It's going to be preventing the motion of hyperextension. So anytime you hyperextend your back, too much, this hyperextension, this ligament is going to be the one that's preventing that force from happening. The next ligament right here, very thin ligament. So this one was thin, and the one next to it, broad. Now, this is your PLL. So just a quick overview. PLL, this essentially is going to prevent your hyperflexion of your torso. Now I'll go into the quick mechanisms that deal with this, but essentially, again, this is the reason why it's thin. This is important, and we'll talk later about the herniations, and you can essentially have lateral herniations, which will actually wrap around the ligament. Next in the line, we'll do in red. This is going to be your, and this is one of my favorites, the ligamentum flavum. So the ligamentum flavum essentially is going to be on the anterior side of the vertebral foramina. So just right here. So what this does is that it essentially, now the reason I drew these, this came out wrong, so let me actually fix that real quick. Come on. So this essentially is going to be located in gray, and it's going to be connecting spinous process to spinous process. So these spinous processes here, imagine you have a whole list of them connecting all each other. This is kind of your ligamentum flavum. It's running on the interior portion right here. Now this ligamentum flavum, due to the nature of its positioning, this also prevents hyperflexion. Now, prevention of hyperflexion is because, again, when you want to bend forward, it's going to resist and bend the other way. The next ligament that we're going to be going over is your the supra, well, yeah, let's do this, the interspinous ligaments first, because this is essentially the ligament. Let's do this in black. It comes in between here. It fills in between the spinous process of each one. Now this ligament, we'll put it over here. These again prevent hyperflexion, but not so well. Because mainly the fibers, the way they run, again, is, so if this was your spinous process and this was another spinous process, you have these ligaments that are running in more of a backwards fashion. Now you can imagine that when you hyperflex, these are going to end up straightening out, shown up here in the bottom. So unless you're really hyperflexing and really forcing them to go the other way, then they're not going to be creating much tension. So not much. So I'm assuming if you get a question about this, the ligaments that are going to be ruptured, more severely are probably going to be your ligamentum flavum and your posterior longitudinal ligament. Only two more to go. We have our supraspinous ligaments, which again run on top of the spinous processes of the vertebrae, just right outside here, again preventing hyperextension. So the big lesson here is essentially the anterior longitudinal ligaments, the only thing that's going to be preventing hyperextension. So you can rupture really any one of these in theory. And lastly, let's go over the ligamentum, or the ligamentum nuchae. Now, ligamentum nuchae, big ligament, and it essentially is going to be connecting to the occipital protuberance, and it basically goes all the way down to the tip of the C7, and it creates this sort of webbing interface. So let's just draw the bottom of the occipital. So there's your protuberance. Let's do some vertebral spines. 1, 2, 3, 4, 5, 6, 7. So it's going to be essentially connecting in to that seventh cervical spine. So again, just a really big web. You have a lot of muscular attachments here, and it's really continuous with your supraspinous. And this ligamentum nuchae, again, it can also prevent, hyper, because it's in the posterior of the skull. It's going to be causing a force to go this way. So when your head hyperflexes in your cervical, this will be preventing it. So this would prevent hyperflexion, mostly for C-spine. Okay, so let's see what's next on the list. Okay, so if you go lower, you can get to the anterior sacral ligaments, and essentially these will lock your spine into place of the sacral joint so it doesn't slip forward. That's really all you needed to know, or the real important aspect, at least for this chapter, for those iliolumbar ligaments and the anterior sacral ligaments. So let's actually start on the more clinical aspects now. Again, sorry for the long intro. I'll fix the actual timing of these lectures, hopefully down to 10 minutes. Really got to work on that. Either way, so let's go over the big ones. This is the stenosis. So what is a stenosis? Stenosis is essentially narrowing to cause compression on any real, this could be a vessel, or it could be really any organic tubular tissue, like a spinal cord, right? So we've already talked about the spondylophytes and how they cause extra bony, matter to accumulate on the uncovertebral joints, and that pushes on your spinal nerve. Let's talk about the spinal cord now. There's a couple of things that can cause this. So, like we said, the ligamentum flavum, looking from a superior view. So this is the vertebral foramina. There's your spinous. These are the laminae. These are the transverse processes, your pedicles, and then essentially the vertebra, right? The vertebral body. So again, looking at it from up, your ligamentum flavum, again, runs on the inside right here. So if you have hypertrophy of this, hypertrophy of the ligamentum flavum, this will narrow that canal that the spinal cord runs through. So it's pretty simple, to see how this tube in here is going to start getting compressed when these get thicker. So there's your first part of a stenosis. It's your hypertrophy of your ligamentum flavum. So to look at the second one, you can have something called facet joint disease. So your facet joints are actually, this is better drawn in a lateral view. These are the superior and inferior facet joints that essentially connect the vertebral bodies, right? So here's your transverse, comes out at you. And then you have essentially these facet joints, and they connect to the vertebra above and the vertebra below. Sorry for the horrible drawing, but it gets the point across. So if you have essentially like a facet joint disease, these joints over here are going to be located essentially right around that vertebral foramen. Now, the spinal cord is there, so we know what's going to happen. It's just going to cause essentially stenosis on the actual spinal cord. So again, you have the thickening of these facet joints right around this area. If they get thicker and wider, looking at it from a top view, again, they'll be getting thicker and wider in these areas. Again, pushing on that spinal cord, right? So this is your facet joint disease. Another name for the facet joints, again, I hope everyone knows this, zygophageal. Okay, so now we have two. And let's jump to the final one. So in between these joints, you have your intervertebral discs, your IVs, right? These intervertebral discs, again, looking at them from a superior angle, start with this big, round, fibrous covering. Again, I think the best analogy for this is a jelly donut. You know, you have this tougher outside, and on the inside you have this nice, juicy pulposa. So basically, the inside will be called your nucleus pulposa, and I hope you guys know this. Where does this come from? Embryology? Notochord. I know we don't need to know that, but you know we'll get quizzed on it. And the outside is your annulus fibrosus. So the annulus fibrosis, when this degenerates, so essentially when you put pressure, so let's draw almost a cut it in half picture, right? And you look at the annulus fibrosis, again, it protects this nucleus pulposa in the middle, okay? Now the nucleus pulposa provides almost like a cushioning. This is your shock absorbers for each and every vertebrae, except for C1 and C2, because C1 does not have a body. So at this point, what you have is essentially two vertebrae sitting in between here. And imagine you put huge compression downward. These will squeeze outward. Water in the hydration inside of the nucleus pulposa causes, again, this kind of nice cushiony feel for your vertebrae. Now, let's go back and remember that we have our posterior longitudinal ligament, very thin. Because it's thin, this will cause a wraparound. This will cause the so if your annulus fibrosis degenerates, you grow old, you lose some of the liquid inside of it, whatever it may be, you can get a herniation. And a herniation will allow this nucleus pulposa to end up squeezing outward. And of course, where do we say our spinal cord was? Right there. So there's your spinal cord. So with here, you can, again, of course, create another stenosis of the spine, and the herniation will cause pressure on the cord, pain, lower back pain, get into an accident, you herniate a disc. The most important thing to know here that they may bring up is if you have two discs, and I'll draw the other one in a flexion. This is what the discs would look like in forward flexion. It's actually a bad drawing. Let me redo that for you. So just a quick one. You have two angles. So your annulus fibrosis is going to be compressed at one side and going to have tension on the other side. Now the tension is usually going to be what can cause this break. within the actual annulus fibrosus, allowing the herniation because it's going to be squeezed out almost like a tube of toothpaste. There is another type of herniation. It's interesting. So those are the stenoses. This type of herniation is not going to actually cause a spinal stenosis, but what it's going to do is it will cause vertical herniation, and you get these nodes that are kind of prominent within the vertebrae. So some of your vertebrae will actually look like dips. And these are sites where your annulus fibrosus and your nucleus pulposus, or well, more your nucleus pulposus, has actually herniated inside of one of the discs. So there's your nucleus pulposus. It can actually go up into these. Now these nodes right here, they are called your Schmorl's node. And just something to be aware of. Of course, for the final topic, just to go over real quick, two big ones that I think are important. You have your spondylolisthesis and your spondylolisthesis. So I hope you guys have heard of the Scotty dog, because this has everything to do with your Scotty dog. I recommend you Google it, look at a picture. Essentially, these two are going to be talking about your pars interarticularis. That's what it's. This is what it's concerned with. And if you guys are confused, this is the neck of the Scotty dog. So spondylolysis is essentially just a unilateral fracture. You're probably not going to get any slippage, mainly because that's what spondylolisthesis is. It's anterior slippage, probably spelling that wrong, of vertebral body. The big thing about this that you guys should remember is it depends where the actual fracture takes place. So if you have let's do the lumbar spine. If you have a lumbar spine, right, and you have right there, at the lumbar spine, the Scotty dog break, the pars interarticularis, that break has to be at the lamina. So again, lumbar lamina. So if a guy gets into an accident, he has anterior slippage of his body for L4. That's a laminal break, bilateral laminar break. For your cervical, of course, same concept, except it's at your pedicle. So for the cervical, let's do C4, C5. Right, they're not going to have really those transverse processes. They have the lateral processes. Those are going to be at the pedicle, which would be this break right here. You'd only need one. It would cause slippage of one of the cervical spines. And that's about it. There is a couple more things to go over. Just be familiar with the different types of spinal curvature, your scoliosis, the lordosis, and the kyphosis. And it would help to be aware of how would you differentiate between left sclerosis or right left scoliosis or right scoliosis. And this is mainly looked at for the pelvis. You look at the tilt of the pelvis and how it's deviating. And so if it's deviated to the left, you could call this left scoliosis. Hopefully they don't get into too much detail. I guess we could do a quick one. So it looks like the S-shaped spine, right? Lordosis, you're looking at your lumbar curve. So you have a nice straight back, and then all of a sudden you have a really big curve. So this is from the posterior view. And then this is from a sagittal. Right, so you have very big curvature in your lumbar spine. Kyphosis is the exact opposite of the lordosis. Kyphosis, you're going to have almost like a hunchback. So really big prominence and then normal on this line. So that looks like a question mark. Like, why are we all in med school? Okay, guys, hope you enjoyed the lesson. 36 minutes, I think that wasn't too bad. I know we all have lecture over and over, but I think it's a nice, just quick review if you have to look at anything specific. If you like the video, share it with your friends. If not, dislike me to hell. I don't know. We'll see if I'll start asking you to subscribe. I doubt that'll happen. Anyways, I hope you enjoyed the video, and we'll see you guys bright and early tomorrow. Thank you.